Good afternoon, and thank you for joining us today. My name is Carlin Tancioko. I'm a registered nurse and advanced practice consultant with the practice support team here at CNO.
And my name is Erin Tilley. I'm also an RN, and I work at CNO on the strategy team.
So over a year ago, we embarked on a journey to learn more about sexual abuse and about what leads to nurses sexually abusing patients. This is work we chose to do because we believe that if we can understand what leads to nurses sexually abusing patients, we can prevent it. We believe this work will make a difference to patients and the public by preventing harm and suffering. So today, we will provide an overview of what sexual abuse is, discuss the research behind it, explore the different strategies to identify who to help and how, and finally, how we can work together to prevent sexual abuse. If you have questions, please send them by chat to the host. We have a colleague, Elizabeth, in the room with us today who will be monitoring the chat for questions. We will respond to them at various points through the presentation and also at the end of the presentation. In today's presentation, we would like to keep these questions in mind. Is adding a patient on social media a boundary violation? Is it appropriate to accompany a patient to a coffee shop when it is part of their plan of care? Is a sexualized comment about a patient considered sexual abuse? Later on in the presentation, we will discuss these topic areas in some case studies. So what is sexual abuse? Sexual abuse by health professionals is defined more broadly than sexual assault under criminal law. Health professionals are accountable to a law that puts the needs of patients first. There is a specific definition of sexual abuse for regulated health professionals, and it's found in the Regulated Health Professionals Act. Sexual abuse is sexual intercourse or physical relations between a nurse and patient, touching of a sexual nature of the patient by the nurse, behavior or remarks of a sexual nature by the nurse towards the patient. Behavior or remarks of a sexual nature by the nurse towards the patient is also considered sexual abuse. In Ontario, there is zero tolerance for sexual abuse. Suspicion of sexual abuse is a mandatory report to CNO. In many cases, as required under the Regulated Health Professionals Act, a finding of sexual abuse results in a revocation of the nurse's certificate of registration.
How is a sexual relationship sexual abuse? So let's reflect on whose needs are being met, the patient or the nurse. Patient needs should always come first. Engaging in a sexual relationship infringes on that goal of providing patient care and causes harm to patients. Sexual abuse by an authority figure, and that could be a healthcare provider who has power over a patient, plays havoc with a patient's thoughts and emotions. Some of the feedback that we've had from patients who have reported sexual abuse to us is that they feel violated, they feel vulnerable and ashamed, and they feel confused. Sexual relations with a patient is never justified. Patients have the right to be treated in a competent, ethical, and respectful manner. There is a power imbalance between a patient and a nurse. Some of what makes a patient vulnerable includes that they disclose private information to the nurse. They may also have intimate physical exams. They may be feeling ill or in pain. They may be anxious about their health condition, and some patients aren't comfortable questioning a healthcare provider. Some also may have a particular vulnerability because of a condition, for example, or a medication they're on, and this may result in them being unaware of their surroundings, for example. Conversely, nurses are in a position of power. They have personal information about the patient. They may perform intimate physical exams. Nurses have specialized knowledge and training, and this is knowledge and training that the patient is dependent on, and they are in a position of authority over the patient. So although a patient may perceive that they're consenting to sexual relationship, the power dynamics between a patient and a nurse don't enable the patient to actually consent to a sexual relationship. Research shows that sexual abuse is underreported. In fact, the estimates in the research are that 90% of sexual abuse is underreported. A patient may not report because they may fear that people won't believe them, or they may fear that they may not get the treatment that they need. So what is reported to CNO, what we know, our data, is limited. We know that not all sexual abuse is reported. So that underreporting of sexual abuse is an important lens when we're thinking of our discussion today and later on when we're talking about CNO's research findings. And equally, there's another important lens to keep in mind. There are approximately 180,000 nurses registered with CNO, and most of these nurses provide excellent patient care. Most nurses do not harm their patients. Even taking underreporting into consideration, our data tells us that it is a small number of nurses who sexually abuse patients. And yet the trauma of sexual abuse can be lasting, and some patients never recover from this trauma. Even though the numbers may be small, it is worth the effort in terms of preventing this grievous harm. Before we move into the next section of the presentation, we wanted to provide you with an opportunity to ask any questions you have about the definition of sexual abuse. So our next two sections will be looking at the evidence and also looking at what we can do to prevent sexual abuse. If you have any questions about the definition of sexual abuse, you can send them through that chat function now. We'll share your question anonymously and respond to it. While you're sending those in, we did get a couple of questions when you registered for the webcast related to the definition of sexual abuse. So Carlin, is there a different timeline for avoiding relationships with patients who have a mental health condition?
So the answer to this question is no. The same timeline still applies regardless of the patient population or the patient's diagnosis. The nurse must not engage in a personal friendship or romantic relationship or sexual relationship with that patient or the patient's significant other for 1 year following the termination of a therapeutic relationship. So this timeline applies regardless of the patient's population or diagnosis.
And another question that was sent in during registration, also related to the definition of sexual abuse, is it appropriate to touch a hand or shoulder when a patient is in crisis? And this person wrote that using your hand could be a reassurance and comfort to a patient and help them overcome a crisis.
So there are definitely times when it is appropriate to touch a patient, provided that it's serving the patient's needs and not the needs of the nurse. For example, when a patient may be in crisis, for example, a patient may be experiencing the death of a child and requires and is seeking support and reassurance from a nurse. So it may be appropriate for this nurse to place a hand on that patient's that shoulder or provide them with a hug.
Did we get any other questions in? No? Okay. So we'll move on, but feel free to send your questions in over the course of the presentation, and we'll certainly have time again at the end of the presentation to answer your questions. To better understand sexual abuse by health professionals, we conducted 2 literature reviews, and we also interviewed international sexual abuse experts, and these included clinicians, advocates, and researchers. We also wanted to understand our own data and conducted a research study looking at our sexual abuse data. And over the next few slides, I'll present some high-level findings from that research. We identified every sexual abuse matter that was received by CNO over an 18-year period from the year 2000 to the year 2017. When I refer to matters, I'm referring to complaints and reports. So a complaint is often received from a patient or a family member, whereas a report is often from an employer or a healthcare provider, such as a nurse. So over the course of that 18-year period, we had 280 matters that came to CNO. These involved 264 nurses and 337 patients, which means that some matters involved the same nurse and some matters involved more than one patient. In our analysis, we found that most of these matters involved adults, with 15% over the age of 70. 53% of the patients were women, and 46% were men. The most common area of practice where the alleged incident occurred was in mental health, and this was followed by geriatrics and home care. I'll give you one example from our case files just to illustrate what this might look like. In one case, over a year and a half, while this individual was an inpatient, outpatient, and former patient, the nurse gave the patient gifts such as a teddy bear, jewelry, cards, and the patient stated that they engaged in hugging, kissing, and sexual relations, including over a weekend when the patient had a leave pass from her admission. The risk of a sexual relationship developing does seem to be higher in care settings where there's prolonged patient-nurse contact. This slide depicts the most common types of sexual abuse. Some matters had more than one type of sexual abuse, and we captured each type. So 51% of the matters, so that's out of the 280, involved sexual touching of a patient. 36% involved sexual remarks, and 20% involved kissing. So I'll just give a couple of examples for the first two on this slide to give you an idea of what that might look like. With respect to sexual touching, one example is a nurse who was observed leaning over the bed of an unconscious patient, touching the patient's breast. In terms of sexual remarks, the most common sexual remarks would be a nurse commenting about a patient's body part in a sexually suggestive manner. We coded for attributes that may have made the patient particularly vulnerable. For example, patients who are unaware of their surroundings because of a condition or perhaps because of a medication that they're on. So their judgment or their understanding of a situation may be impaired. Not every patient had a particular attribute that may make them more vulnerable, and conversely, we had some matters where patients had more than one of these vulnerabilities. As you can see on this slide, a third of patients had mental health conditions, 15% were elderly over the age of 70, and 11% each had cognitive and physical impairment. So again, these factors may make them more vulnerable if they're not aware of their surroundings and what's happening to them. When we looked at the incident, we looked at what behaviors preceded sexual abuse. Grooming techniques are techniques that can be used to draw a patient in or to build trust with a patient. Why is this important? If we can understand what precedes sexual abuse, then we can potentially prevent sexual abuse from happening. In CNO's research, the most common techniques were spending special attention or giving special attention to a patient. So this could be spending time with a patient before or after shift, or giving a gift to a patient. Another common technique was sharing personal information with a patient. So what that might look like is the nurse sharing personal information about a romantic relationship that they're having that isn't going well. The other common technique that's used is communicating electronically in a personal way with the patient. And in some of the matters that we looked at, there was more than one technique that was used. So our research was one form of evidence that has informed this work. We looked at CNO's research findings in comparison with other forms of evidence, and I've highlighted on this slide some areas of commonality. Vulnerable patients are targeted. Healthcare providers seek opportunities to be alone with the patient. And there is a progression of behaviors before sexual abuse. And again, this is an opportunity for prevention if we can understand what some of these behaviors are. Healthcare providers are often mid to late career, and they often have a history of other conduct matters, and these aren't necessarily matters that have come to CNO. They could be workplace conduct issues. So at this point, we'll pause before we go into the last section of the presentation with respect to how to prevent sexual abuse. And if you have questions about CNO's research or other forms of evidence than we looked at, we welcome you to send that in through the chat function. Again, we will share your question anonymously and respond to that. Any questions? So the first question is, should you be asking for consent before you touch a patient?
And the answer to this question is yes. There's always it's always appropriate to ask for consent prior to touching a patient.
So I can answer this one, Carlin.
Sure.
The question is, what role does intention play in sexual abuse? And that's a really interesting question in terms of sort of the profile of what someone who sexually abuses looks like. So really, you could consider there to be two profiles, and one is a predator, and that's someone that intends to cause harm, and the other one is, potentially a nurse that's crossing boundaries, and those boundaries could lead to sexual abuse, and it wasn't their intent to cause harm to a patient when those decisions were made. When we did our research, we looked at whether or not we could look at our data in two separate ways, because one of our hypotheses is that the risk factors and what potentially leads to sexual abuse may look different for those who really intend to cause harm, the predators, and those who didn't go in intending to cause harm. And unfortunately, we couldn't look at our data this way. What we've tried to do in terms of developing our resources is incorporated content that would be relevant to both of these profiles. So in terms of some of the warning signs, for example, in terms of speaking up about concerns, and Carlin's going to get into a little bit more detail about that in the next section. Are there any more questions right now, Elizabeth, or shall we?
You will continue, and I will.
Okay, all right, great.
So the results may be difficult to hear. It's not easy to hear that vulnerable patients may be taken advantage of. So as mentioned, we are using several different forms of evidence to understand the problem and inform interventions that we are developing this year. Our first intervention relates to sharing what CNO has learned, which is one of the reasons we are here today. We are looking for opportunities to partner with others. In fact, we have been sharing our research with other stakeholders and are seeking opportunities to collaborate with partners in the system. Preventing sexual abuse can happen if there are changes at all levels, including system, organizational, and individual levels. With our second intervention, we're supporting continuous improvement here at CNO. We continue to seek ways to support patients, and we have made changes based on the evidence to policies and procedures in professional conduct. A sexual abuse expert is conducting a sensitivity review for all public-facing sexual abuse information, for example, to ensure that our language would not cause distress to a victim. Lastly, we are developing new content that will be reported on annually related to sexual abuse. Our third intervention is about education. We plan to educate nurses and other stakeholders on the importance of identifying and preventing sexual abuse by communicating this important work to key stakeholder groups, such as nurses and employers, and developing new resources, such as fact sheets on key topic areas, such as boundaries and self-care. It's common to have a reaction to this information, that this would never be me, or my colleague would never do this. Our research shows that it can be anyone. Not all nurses understand that a sexual relationship with a patient is sexual abuse. We have developed content for CNO's website, including frequently asked questions, as well as a new fact sheet that helps stakeholders understand how sexual abuse is defined. One area that we are educating others about relates to evidence that there is a progression of behaviors before sexual abuse, as Erin mentioned. That means that if we can stop those behaviors, we can prevent some sexual abuse. So what are some boundaries that are crossed that can lead to sexual abuse? If we can identify these in ourselves and in others, we can support one another so we are not crossing boundaries. By raising issues that can lead to patient harm, we can work together to make the environments that we work in as safe as possible for patients. We are also developing fact sheets related to supporting a safe culture to assist nurses and others in bringing issues forward in a constructive and patient-focused manner. We've adapted the following resource from the College of Physicians and Surgeons of Ontario to reflect the slippery slope that can begin with a boundary violation. It's important to remember that not all boundary violations will lead to sexual abuse, but they have the potential to. Boundary violations can result in the discipline of a nurse. Following a pattern, this can then lead to sexual abuse. You'll see that there are many stop signs along the way in this resource, spanning across the slope, where nurses have and can stop, pause, reflect on their practice, and make the necessary changes to ensure the protection and safety of patients. Research shows that physical and emotional fatigue can reduce cognitive functioning, including decision-making, memory, and attention. As nurses, we are in the best position to care for ourselves and for our patients when we take care of ourselves. In fact, nurses taking care of themselves not only benefits patients, it benefits nurses, as research shows that there's increased job and life satisfaction and generally better physical health. It's important to take a step back to identify what these issues are and to deal with stressors in and out of our personal and professional lives. So to assist you in applying information today, we'll now review a couple of case studies. So here's the first case study. Yotam, a nurse, works on a busy surgical unit. Yotam spends more time with one particular patient, Charla. Yotam eventually adds Charla as a friend on social media. So here are some questions to consider as you work through this scenario. Was it right for Yotam to add Charla on social media? Has Yotam violated a professional boundary? If so, in which and in what way? So we're now going to pause for a minute to allow you to reflect on this scenario. And at this time, please feel free to send any questions or comments to the host through the chat.
Let us know if you get any feedback about that first case study. Okay.
Oh, what if a patient confides in you that they have been sexually abused by an RN but does not want to make a formal complaint with the CNO?
Okay, we can address. Okay, great.
Social media is a potential boundary risk. This is because social media is a public forum. It can be accessed by anywhere and at any time. It is used to share personal information, such as videos and photos. It can be viewed by patients, family, and friends. It also provides a venue to exchange informal texts and emails with patients. In this forum, relationships are no longer professional and they become personal. In this scenario, the reason for adding Charla on social media does not appear to be connected to a therapeutic need. Instead, it appears to be connected to Yotam's personal needs or interests, and therefore contacting Charla in any way for this purpose is not appropriate. Yotam inviting a patient as a friend on social media for personal reasons is a boundary violation. A nurse must abstain from disclosing personal information to patients, and as previously mentioned, social media discloses very personal information about a nurse. Social media also reveals personal information about a patient and their personal life, and there is a potential for a nurse to misuse this information as they are in a position of power. Here's a second case study. Miguel is a nurse working in a mental health facility. Kate, his patient, has it written in her care plan that she is to be accompanied by a nurse to the local coffee shop for lunch. Miguel is to assess how Kate copes in this situation. Miguel wonders if this is appropriate and if this is a boundary violation. So again, here are some questions to help you reflect on this scenario. Is it appropriate for Miguel to accompany Kate to the coffee shop for lunch? Is this a boundary violation? What standards is Miguel held accountable to? So again, we're just going to pause for a minute to allow you to reflect on this scenario. And at this time, please feel free to send any comments or questions to the chat.
Case study? No, okay.
In this situation, it is appropriate for Miguel to accompany Kate as this is part of her plan of care. By accompanying Kate to lunch, he is using this as an opportunity to assess how she copes in a social situation, and this is meeting her needs and not Miguel's needs. He is gaining an understanding of the patient's abilities, limitations, and needs related to her health condition, which is an accountability found within the therapeutic nurse-client relationship practice standard. When situations like this arise, nurses are accountable for ensuring that their interactions with patients serve to meet patient needs and not their own needs, and that they're consistently maintaining professional boundaries. Here's the third case study. Talia and Adam are nurses working in a long-term care facility. While changing a patient's incontinence brief, Adam hears Talia make a sexualized comment about the size of the patient's genitals. So again, we're just going to pose some questions to allow you to reflect on this scenario. Is a sexualized comment reportable? What should Adam do after observing this encounter? So again, we're just going to pause for a minute to allow you to reflect on this scenario. And again, at this time, please feel free to send any comments or questions to the host. It is the nurse's responsibility to maintain professionalism in a patient encounter, and failure to do so is a boundary violation. Regardless of this nurse's intent, the use of sexualized jokes and comments is regarded as sexual abuse under the Regulated Health Professions Act. Accordingly, Adam has a duty to report sexual abuse and use of sexualized comments and jokes in this scenario because it is sexual abuse as defined by law.
As described by Carlin, a sexual relationship and sexual comments are sexual abuse. So what can we do to prevent sexual abuse? The first is raising awareness. As Carlin mentioned, we've had feedback that suggests that not everyone understands what that legal definition of sexual abuse is for healthcare providers. So one way you can help to prevent sexual abuse is by sharing with others what that definition is to increase an understanding of the definition of sexual abuse for healthcare providers. Also, you can have a role in sharing reporting requirements for nurses and employers, and it is a legal accountability for both nurses and facilities to report suspicion of sexual abuse. Also, bring patient safety concerns forward early so they can be dealt with before they escalate. As indicated in that one slide that Carlin presented, boundary violations, while they may not lead to sexual abuse, they can lead to sexual abuse, and both boundary violations and sexual abuse can harm patients. Understanding warning signs so you can intervene before something may lead to sexual abuse is another way to prevent sexual abuse. And related to that, and Carlin alluded to this as well, we have developed a number of new resources, and they will be available in the near future through this link. We have 5 new fact sheets coming out. So one, Carlin already mentioned, we have one related to the definition of sexual abuse. We have another one related to how to support a safety culture in the workplace, how to foster that environment where staff bring concerns forward and they're dealt with constructively. We have another fact sheet related to warning signs that can precede sexual abuse to increase awareness of those so you can intervene before the potential for sexual abuse is there, and also strategies to support self-care. Another resource that we're working on and will also be available in the near future is an employer toolkit, which will have a number of additional resources in addition to the fact sheets. We are also adapting some case studies from the College of Physicians and Surgeons of Ontario, and these case studies look at both boundary violations and sexual abuse, presenting them in a case study format where you have some questions where you can think about the case study and then responses to those questions. So this could even be an opportunity for nurses to get together, for example, in a lunch and learn to review the case studies. We've also developed new content for our website, and that is up. And as we have new questions that come in, we will be adding to the frequently asked questions. And again, all the resources will be accessible through this web link. So that concludes the former part of this presentation. So at this point, we are really interested in receiving your questions and your comments. We have a number that have come in over the course of the presentation, and we'll respond to those now. And we also had 2 questions that came in when you registered for the webcast. So I'll start by asking Carlin those questions. So first of all, Carlin, how do we encourage all nursing staff to speak up when they see something concerning?
So we encourage all nurses to really take a positive approach to this and focus on prevention of sexual abuse. This demonstrates a commitment to continuous improvement, and where this is relevant, we want to let the staff person know what was done and the information that was shared. So as Erin mentioned, there is a fact sheet coming out that talks about having these difficult conversations with others that will be helpful in really targeting these types of conversations.
And the other question that came in during registration is, whose responsibility is it to report to CNO, the employer or the nurse?
And the answer to this question is that it is both the accountability of the nurse and the employer to report sexual abuse, and this is outlined in law. Again, there's new information on our website related to reporting requirements, and there's more about this coming out later this year.
Okay, and now we'll respond to the questions that are coming in now. So Carlin, one of the questions is, what if a patient confides in a nurse that they were sexually abused and the patient doesn't want this reported? Did you want me to answer that question? Then you can add to it? Yep. So the nurse, as Carlin just mentioned, has a duty to report. It's a requirement in law. The client's name or the patient's name does not have to be disclosed. So if there isn't consent to share that patient's name, then you wouldn't share that information. Do you have anything to add?
No, that's it.
There was another question that came in around trauma-informed care. And the comment from this individual said that trauma-informed care tells us that certain childhood experiences can be repressed and triggered by certain care approaches. How do we empower staff to be aware of this, and that the care approaches might not be sexual in nature or intended to be sexual in nature, but is it possible that the patient could perceive it this way because of their traumatic history?
Right, and that's a great question. This is something that we've incorporated in the new concept for the employer toolkit. And again, it can happen where a patient may misinterpret a clinical procedure as sexual abuse. So an excellent example of this is a catheter insertion. So again, this can be easily mitigated using communication, so effective communication strategies, asking for the patient for consent prior to the procedure, and informing the patient along the way of what exactly is happening during the procedure so that they're aware that it is related to a clinical need and not related to an abusive type of act.
There was another question that came in. There's 2 related to the research, so I will try to answer those, and Carlin, please add. So the first question is, did you look at the gender of the nurses who committed the alleged sexual abuse, and what does that data say? So that is something we looked at, and in terms of, again, those 280 matters that we looked at CNO, 51% of nurses were female, and 49% of nurses were male. And as you are likely aware, if you compare those percentages with the number of females and males registered with CNO, there are more females registered with CNO. So that does say that males are overrepresented in those numbers. That is a common finding in the research, so that wasn't isolated in terms of what CNO saw in the data. But again, it could be either gender. Our data tells us that as well. The other question regarding the research study relates to comments that I made about that distinction between the intentional harm versus unintentional harm and why we couldn't look at that with our data. And the simple answer is, in some cases, it was really clear cut, and you knew that the intention was there to cause harm. And in some cases, it was clear-cut that you knew that wasn't the intention. There were many cases where the intent of the nurse was unclear, and we just couldn't make assumptions about that. So we didn't have the level of detail needed to really divide up our matters in that way. Another question, Carlin, that wasn't related to the research. In long-term care homes, residents usually touch staff or sometimes even hug or kiss staff, but not in a sexual way. And should staff hug them back?
Mm-hmm. And I think this was covered in the case study earlier today, where we talked about when touch is appropriate for patient care. And I think it's important for nurses to reflect on, you know, is this hug or this act of touching meeting the patient's needs or the needs of the nurse, and really defining what that would look like in that patient's plan of care. Again, it's always important to ask for consent and to ensure that this is something that's meeting the therapeutic needs of the patient and not the needs of the nurse.
So there's a comment, this is related to the research study, so I'm happy to take this one, Carlin. So that we're concerned that the research study does not distinguish between founded and unfounded matters. And so it's measuring, the data is measuring allegations. And that is true. So we looked at 280 matters that were reported over an 18-year period. And what that means is that we looked at all allegations of sexual abuse. Without getting into too much detail, what I can tell you is that there are very few sexual abuse matters that end up going to discipline. Mm-hmm. So if we were to rely on only that small number that have a discipline finding, we knew we would be missing a lot of data. So that is a limitation in our data set, and one reason why it was one piece of evidence to inform the work that we're doing now, really related to the prevention of sexual abuse. So I'll just give you a couple of scenarios to explain that a little bit more. So it is common for a patient or a client not to want to participate in CNO processes. And this is common in criminal cases as well. It can be very re-traumatizing for a victim to participate in processes. And in reviewing our case files, there are healthcare providers who recommend and tell their patients not to participate in our processes. They don't think that they're in a state where that would be beneficial to the patient's health. So that's an example of one reason why something may not go through our processes, because without certain evidence, obviously something can't go to discipline committee. So that's an example. What that means is we know that likely there are false allegations of sexual abuse in our data set. We also know from research that the number of false allegations are low. So it seems like a greater risk not to look at all of our data, knowing that relying on the evidence and other research studies that false allegations are generally a really low number. But again, that being said, our work and the research that we did is just one form of evidence that we have used. We interviewed sexual abuse experts. We conducted 2 big lit reviews, but a lot of little literature reviews as well related to specific matters, for example, related to self-care. So that's how we've mitigated that limitation. And another limitation of the data set is we only know what's reported to CNO. So I mentioned earlier in the presentation that approximately 90% of sexual abuse generally is not reported. So we also only know, maybe 10%, that's a guess based on other studies, but we only know what's reported to CNO. So next question for you, Carlin, relates to one of the case studies where the nurse makes a comment about the client's genitals in a sexually suggestive manner. And would the initial report be made to the supervisor or directly to CNO?
So this is a great question. Again, we would hope that employer policies would align with the expectations outlined in the legislation. So for example, there may be employer policies that discuss a chain of how reports should come forward. So we would encourage you to review what these organizational policies may look like in your organization, but also looking at your broader legislative requirements as well. Okay, so the next question also relates to
our research, and of course there is other research that looks at care settings as well, but what I do have on hand is our research results, and the question is if there's any statistics on sexual abuse in home care. So it is the third most common area of practice where we've had allegations of sexual abuse, and we did look at our results related to other forms of evidence as well, and there was really close alignment with what we were seeing in our own data set. But certainly if this individual is interested in more information, you can send a question into practice support. I just realized that the link wasn't on the website, and we can certainly point you to some other resources as well. Another question for you, Carlin. If the patient confides in you that they have been abused by another staff member, who should the nurse report this to?
Mm-hmm. So again, this sort of aligns with the previous question that was asked about employer policy. So looking at what the employer policy states about reporting requirements within the organization as well. But if that staff member is a regulated health professional, nurses do have an accountability to report sexual allegations of sexual abuse to the appropriate regulatory college.
We have a couple more questions coming in right now, so just waiting for Elizabeth to write those down, but please send in any additional questions or comments that you have. We still have 15 minutes, so if there are questions, we have more time. So this question is about what the nurse's responsibility is in reporting patients' attempts of sexual touching. And is this touching subjective to what makes one feel uncomfortable or specific to certain parts of the body being touched? Mm-hmm. So in terms of a patient making advances on a nurse, and what are the nurse's responsibilities in that, in that instance?
Right. So this goes back to the accountabilities outlined in a therapeutic nurse-client relationship standard, where it would to ensure that professional boundaries are always maintained, and making sure that the patient is aware of what the nurse's role in their care plan is, and to ensure they have that type of conversation. Nurses are also encouraged to have these broader conversations with their healthcare teams, such as their employers, and perhaps this may be an opportunity to brainstorm some strategies to help target that specific topic area, because it is very challenging.
And maybe related to that second part of the question and that that subjectivity, I'm just thinking about it related to patients. It is about how that patient feels and is interpreting the action. So I think Carlin was talking about the importance of ensuring informed consent, explaining things throughout so nothing is misinterpreted in terms of the care being provided and nothing is unexpected. But that's just something important to keep in mind as well. Okay, we have at least one more question coming in, so we'll just wait while Elizabeth writes that down. So the question is, can you please refer me to the specific legislation or regulation that has been referred to in the presentation related to sexual abuse? Since it does appear that the CNO definition is different from the criminal definition, and yeah, we can certainly send that that link out to participants. We will have a follow-up email. We'll be asking for your feedback in terms of this presentation. And one thing I wanted to mention, this is a new form of technology that we've used, so we'd love your feedback on that. But as part of that email that we send out, we can certainly provide you with a link. It comes from the Regulated Health Professions Act. So that means that's the law that governs practice for all regulated healthcare providers. So the same definition applies for physicians, for occupational therapists, for respiratory therapists, physiotherapists, et cetera. So it's that that main piece of legislation, but we can certainly send that link to participants. Okay, so the question is, you mentioned that CNO would not be able to proceed to a discipline process without evidence. And does this involve the patient who lodged the complaint testifying? Did you want me to respond to that? So there would always have to be evidence to inform a decision at discipline committee. And one thing we saw in evidence and information around sexual abuse is it often happens in private. So evidence may be really minimal, and it's possible that the only evidence is might be related to the victim testifying. So so it is possible that without evidence that the matter wouldn't proceed through for a sexual abuse allegation. It could be that there are other conduct matters or conduct issues that are investigated as part of the process, but certainly there would have to be evidence to support a decision at discipline committee. Okay, so it appears that there are no more questions at this time, but you are welcome to send a question into practice support. That's the link on this website if you have a question that comes to mind afterwards, and we'll certainly send out that evaluation form, and we would love to have your feedback in terms of what went well and what we could improve next time, and we'll also send that link to the regulation. But we thank you very much for your time today, your engagement, and participation.
Thank you.
Take care.